I begin, let me thank the Health Council and particularly the Mental Health Committee for having me here. I'm very excited. I don't think I have been in downtown Hartford before. I was saying that last night, and it is a very attractive city, so I will be back. I also want to thank Oz. I've decided that should he decide to run for office again, I will move to Connecticut and campaign for him. He was a very charming dinner companion, and in fact interviewed Kim and I thought he was a professional radio person. So he is quite skilled. Also Amy Cunningham, who has taken very, very good care of me, and that is only matched by Kim herself, who actually picked me up at the airport. Usually I'm wandering around looking for a cab. I'm not used to all of this TLC, but it's been just lovely. And she, of course, is a member of the National Council, a great organization that is really on the cutting edge, as are many of your Connecticut organizations. And I also want to acknowledge my boss, the head of my board, Jeff Walters, who ran the Reshford Center for years and now is a national consultant on things like integration of mental health, substance use, and primary care. I'm joined by an amazing panel. I can't wait to hear what they have to say, and we'll go over who they are as soon as I'm finished. And I think hopefully you will ask some very provocative questions so that we can have a really honest and open discussion. So without further ado, because I want to leave plenty of time, let me begin. I'm going to be talking obviously about mental health. I've spent the last 40 years in working with people in all kinds of positions, myself, people with serious mental illness, so it's something I am very committed to. And we're going to try to do three things. We're going to talk a little bit about mental health equity and the promise of healthcare reform, specifically the Affordable Care Act. We're going to talk about the state of care for people with serious mental illness, and then what needs to be done. And your panel will be talking about what you're doing right here in Connecticut. But before I begin, I thought what I would do is tell three very brief stories to kind of give you a sense of who we're talking about. You know, mental illness is a very big term, and it encompasses lots of disorders, anxiety, depression, schizophrenia, bipolar. And so today we're really focused on people with the most serious illnesses. And I'm going to tell you the story of three people: Timothy, Gabriel, and Shirley. Timothy, 21, was a young man with serious mental illness. His trouble started in his late teen years, which is very often the time of onset of schizophrenia. He ran around outside without his clothes, thinking he was a knight fighting dragons, and he was in and out of the hospital. After one hospital stay, he was caught shoplifting 2 paintball guns. He grabbed a pocket knife, threatened employees, and then begged a cop to shoot him. He was stunned with a taser and put in jail. In jail, he tried to kill himself 3 times. He pled to resisting arrest and assault and was sentenced to 3 to 5 years in a Michigan prison with 5,000 other inmates. In prison, he took a shower without permission and was put in solitary. When he flooded his cell, he was chained down, hands, feet, and waist for stretches of 12 hours, 16 hours, and 17 hours. All of it was recorded on a 24-hour surveillance camera. The tape recorded his descent. In 4 days, he could barely walk, he had bed sores, and in the shower, he fell over. Timothy was again chained to a concrete slab until he died of dehydration. And only the surveillance camera took notice. He lied there for almost 24 hours before he was discovered. Timothy's story is one that reminds us of how frail our service system for people with serious mental illness is, and how very often people wind up in tragic circumstances. We do, though, have services like the ones you provide here in Connecticut, which have a much happier ending. On a recent Friday night, the police in Campbell, California, were called EMQ, Children and Family Services. They called them, they're a local community agency. There was a 9-year-old boy, Gabriel, who had a knife to his throat and was threatening suicide. His parents spoke only Spanish and were undocumented. EMQ sent out their crisis team, and a psychiatrist saw Gabriel. They developed a safety plan for Gabriel and began to treat the family and Gabriel in the home. Today, Gabriel lives at home, goes to school, and everybody is getting the help that they need. Shirley, 44, spent most of her life in and out of psychiatric hospitals. She spent time when not in the hospital, in homeless shelters, and living on the streets. Last January, multiple community agencies came together and committed to coordinating services for Shirley. They moved her into an apartment. She agreed to her first apartment she has ever had in her life. They connected her with an assertive community treatment team, which meant treatment came to her rather than expecting her to go to treatment. And 1 year later, she's living successfully in George, Utah. So there are happy endings, and I just wanted to tell those stories so we understand who we're referring to this morning in our remarks. In many ways, the stories of Shirley and Gabriel represent the best of times. In 2008, Congress passed a law saying mental illnesses and addictions were to be treated the same as any physical disorder. George Bush signed that law, the parity law, and the Affordable Care Act in 2012 affirmed that by including mental health and addictions in all aspects of the Affordable Care Law. So these are really the best of times, and you're going to have your insurance commissioner talk a little bit about that and the impact, certainly Pat talking about what your state is doing. But they're also very complex times, because in the United States, we decided we were going to tackle two big problems. One is the quality of care, and the other was the cost of care. And so the Affordable Care Act actually had 4 strategies. The first one being insurance reform. Insurance couldn't deny you coverage because you had a chronic illness. You could stay on your parents' insurance till you were 26. The second was coverage expansion through the expansion of Medicaid, which you've done here in Connecticut. About half the states have done that, and also subsidies through the exchanges. And the last two, delivery system and payment reform, is what we're beginning to experience now, and in many ways are the most complex. Atul Gawande is a surgeon and a policy thinker and writer, and I encourage you, he has a new book out called Being Mortal about aging in this country. I encourage you to read it. But what he said is that insurance reform and coverage expansion are really technical fixes. They're relatively easy. They just cost money. But in fact, we've had some success. Over 9 million more Americans have health insurance since the ACA. The uninsured rate has decreased in the country from 20% to 15%, and health spending remains low. It was well over 6%. It's now 3.7% and steady. So we've made a difference already, and no matter who is in charge in Washington, the ACA will not go away. There'll be lots of posturing about it. Congress will probably put a new law on the floor in the coming months, appealing it, but they don't expect that to happen. The same kind of controversy occurred when Social Security was introduced and when Medicare was introduced. It's part of our American way. But you never take something away once you give it to somebody, and we all know that. The service redesign, the purpose of it is to reduce hospital and institutional care. You're in the Northeast, and there was a study a number of years back by Dartmouth that showed that healthcare costs on the 2 coasts were over twice as much as healthcare costs in the middle of the country. Why? Because we have lots of hospital beds. And when you hospitalize people, you spend lots and lots of money. So the point of the service redesign is to reduce hospitalizations, and it's also to integrate care. Kim talked about that in terms of people with serious mental illness, but it's true for all of us. There was a great article in the New Yorker about a year ago comparing 2 counties in Texas and comparing Medicare spending in those counties, and how one county spent more than any other place in America, and the other county spent among the lowest per capita of Medicare spending. And what made the difference is that in the high-cost county, when you went to the doctor, you had a full battery of tests. And everybody you went to gave you the same tests. They got a CAT scan, they were going to use it, and they were going to bill for it. So the point is to both connect services so you no longer have that duplication, and then to identify your high-cost population. And people with serious mental illnesses and chronic addictions are high cost. They often have comorbid physical disorders due to sometimes the medications they take, sometimes lifestyle, and very often poverty. People with serious mental illness wind up going on Social Security income, on Medicaid, are really driven into poverty because its onset is late teens, and so have all of the conditions that go along with being poor. Half the cigarettes in this country are sold to people with addictions and mental illnesses, and we now know what that causes later on in life. Excuse me. So the ACA is a very, very intriguing bill in many ways. Now, I know you've all heard it was 2,000 pages, and of course, what they don't say is almost every bill is that long. Bills are complex, but it really said, we're going to try a whole bunch of stuff to make care better in this country. And in fact, the Centers for Medicare and Medicaid have an Office of Innovation. And when Don Berwick was the head of the Center for Medicare and Medicaid during the implementation, the early implementation of the ACA, he said, we're going to throw everything against the wall and we're going to see what sticks. Now, no one would have believed that a few years ago, that a federal agency would be that really innovative and inventive. And they had, three ideas among many, many. One is collaborative care, that all of the people who treat you would talk to each other. The other is the notion of a medical home, which actually comes out of pediatrics, and I know you have your head of your children's hospital here, and actually the National Council, with the support of our board, lobbied very hard to have health homes in Medicaid, where people with serious mental illnesses could get both mental health treatment, addiction treatment, and physical care, and I know you have instituted health homes here in Connecticut. And the last, and probably the biggest change that is really sweeping our country and is being tremendously pushed by CMS, are something called accountable care organizations. About half of them are big hospital systems, the other half are big group practices. And they're almost becoming like insurance companies. So they're gonna own a population, they're gonna go at what's called at risk for that population, ultimately getting a payment. We will each have an amount that someone gets paid to take care of us, and if they spend more than that, they're on the hook for it. If they spend less, they actually get to keep some of the savings. And there are some pioneer ACOs in different parts of the country that actually have seen those savings and benefited from them. So payment redesign means all care will be managed. Think back in a way to the 90s and the era of managed care. And there was really a tremendous outcry. People hated that word. So we're not using that word now. We're using collaborative care and ACOs and other language, but it does come down to the same thing, a pot of money that someone's managing for your care to avoid duplication and to improve the quality of your life, all aided and abetted by electronic health records, so people can communicate with each other. The shifting of risk is interesting because right now, most people are paid what's called fee-for-service. You get paid in healthcare for the service you provide. Again, the movement is away from that to either bundle payment, case rates, or really global capitations, where again, a pot of money for your care for the year. And so these organizations are going at what's called at risk. And the result of that is really you need to have deep pockets to be at risk. So we are seeing across the country hospitals consolidate, buy each other, form obviously ACOs, some form insurance companies. And the other interesting thing we're seeing is we're seeing private equity go into healthcare in ways we never saw before. And if you were smart enough to buy some healthcare stocks just a few years ago, you're doing quite well. There is a lot of money in healthcare. Although we're containing costs, the money is moving in different ways, and investment money is really moving in. So we have urgent care, we have retail clinics. I got my flu shot this year in a Walgreens. Last year I got it in Costco. It's what people want, this tremendous convenience. And the other thing we're seeing, because of parity, we're seeing private equity move into private psychiatric hospitals and into residential treatment for addictions. I don't know how all that's going to play out, but it really means that healthcare is part of what we call in this country the monopoly economy. Think about your neighborhood hardware store and Lowe's and Home Depot. Think about airlines. There are only about 4 airlines left in the country. Walmart, 57% of all groceries. And we see that beginning to happen in healthcare. The question is, what happens to the community organizations like Kim's, the community organization that Barry Simon is in the audience and runs, Wheeler Clinic that's also here. And the notion is 2 things would happen for people with serious mental illnesses. Their organizations would actually become part of big hospital systems, deeply embedded, providing behavioral health services, or they would be standalones. They would be like Kim. They would be a health home. They do physical care, mental health care, and addictions, all in one place. And it's a great fantasy, right? It's actually good and often will come true, but it is also a very difficult time. Because at the same time, and I want you to remember back, in the 1800s, state hospitals for people with mental illnesses were the great new thing. They were going to solve all the problems. People would go out to the country, they would have a farm, they would live, beautifully, and everything would be great. Well, when I got out of college, I went to work in a state hospital. And the things I saw, at one point, the psychiatrist on the unit had to medicate me. It was not a beautiful sight. People were marched into bathrooms to be counted at change of shift. People were restrained who disagreed with staff, and both the patients and the parents were really too intimidated to complain. So we knew better, and then we had the financing. Medicaid was developed, and we could begin to develop community services where people could get help, like Gabriel and Shirley, in the community instead of suffering like Timothy. And that was the stage we've been in, for the last 20, 30 years. It was called deinstitutionalization, but we know it didn't work for everybody. And we have people like Timothy in jails and prisons, people like Shirley who live on the streets. And so there were unintended consequences of a good movement where people would not live in institutions that at best are neglectful and at worst abusive, but instead would live amongst us in the community. Now we're moving to the next, really, I think, big transition, and that is integration, where from the silo of being separate and unequal, both mental health and addictions are part of the bigger healthcare world, and organizations are expected to be part of that world. And so we now need to be very careful, because these organizations really are caring for 10 million very fragile, very ill, and costly people who are both socially and clinically vulnerable. They have serious psychiatric illnesses, addictions, physical conditions, but again, as I said, they live in poverty and so have issues of housing and trauma and violence that is perpetrated against them. And so those people have been hidden away for a long time. And probably some of you in this room who are involved in, big hospitals or law firms really didn't give that much thought to these independent agencies that were existing and exist in your community serving these people. But there is much more public awareness now. And people really are telling their story. When I was a little girl and you had cancer, people whispered whispered about it. They did not talk openly about it, and now we all wear pink ribbons. That has begun to happen now with mental illness and addictions. And so it is, again, the best of times because of that. But nevertheless, we still have low penetration in terms of the need. 40% of people who need treatment don't get it. And when you look at addictions, probably 80 to 90% of people who need treatment don't get it. So we still have a lot of work to do, and we still count on those community agencies. And they are dealing with lots of things. So until very recently, in fact, we really knew but didn't think we could do much about the fact that someone who developed serious mental illness wouldn't get the services they really needed until about 7 years into their illness. Because of the way our system is designed, they wound up in emergency rooms or with their primary care physician, and they didn't get known until they were quite disabled. We now know we can intervene at the first psychiatric episode and really make a difference. And I'm sure the panel will be referring to some of those efforts right here in Connecticut. The other thing is that mental illness is still the most common reason for going on Social Security disability. So we have a lot of work to do. And in fact, we have a suicide in this country every 16 minutes. And of the 10 most serious illnesses, 9 of them have been reduced in terms of mortality over the last 10 years. The only thing that continues to go up is the suicide rate in this country. And for people between 15 and 34, suicide is the killer other than unintended accidents. So it is still a very serious issue that we need to pay attention to. And the very organizations that think about this and deal with this have a set of complications. They embrace the idea of integration, but they have really always been managed. Their costs have always been kept under control. And when you look at that chart about healthcare costs and how they were rising for many years, there is an exception to that, and that is care for the most seriously mentally ill and people with addictions. So when we're trying to ratchet down costs, when you're ratcheting down the costs for organizations treating people with serious mental illnesses, you're ratcheting down costs in organizations that don't really have margins. And again, that leaves them in a fragile state and can have people wind up like Timothy did rather than the way Shirley and Gabriel did. The other issue is that those community organizations provide both medical services, psychiatric services, and really social services. And because of the expansion of insurance, many states have really withdrawn their own state money. They say everybody has insurance now. What do you need general fund money? And in Michigan, where I'll be in 2 weeks and where Timothy lived and died, there was actually a crisis around that because they took all the money out of the system, and just now the expansion is taking hold. And so organizations are literally going out of business as a result of that. So they're learning to talk with healthcare, with players, and it's a different language, and with different kind of staff, and that's a stretch, and a skill set people are learning. And they're streamlining operations. One of the things Kim has done brilliantly, and actually Tyler, who's her COO, is helping other organizations, is doing things like same-day access. So if you're part of healthcare, and a primary care doc or a surgeon has someone who needs treatment today, they need to be able to send them and they need to be able to get into care. And for these community organizations, that's a shift. So they're moving away from wait lists. It's not 6 weeks to see somebody, but they're really there when people need them today. I think the other thing we're beginning to see is they understand that they have to negotiate rates. That's also a new thing. It used to be a fixed amount of money you got. Now you need a big backroom operation. You've got 80 different insurance companies you're dealing with. Those are very sophisticated challenges. And with their slim margins, they're unable to make the kind of improvements you need to make, including electronic health records and health information technology. You know that we've got to be texting patients now, right? Just like my dentist therapist. Just text me. I have an appointment next Monday. That's the new world. There are monitors in home that will actually do mental status checks with patients, and you'll only have to deploy a real human being if that data doesn't look good. So we have a world of technology that we have to be able to take advantage of, and I hope some of our panelists will talk about that. We certainly are seeing mergers, and every week we have a member organization that's joining a hospital system. And that is a good thing, we hope. And we hope those hospitals, which are undergoing their own just enormous change, including being penalized for readmissions, will be able to embrace and take on the responsibility for people with serious mental illnesses and addictions. And of course, here in Connecticut, your own governor has announced cuts. The cuts this year, I understand, are nothing compared to the plans for next year. And I would urge you, on behalf of people with serious mental illnesses and addictions, to really help him understand that this is not the place or the time to ratchet down.